Physiology SAQ 16 Obesity. A. Describe the physiological changes in morbidly obese, 8 marks. Introduction. The WHO defines obesity as a condition with excess body fat to the extent that health and well-being are adversely affected. Obesity has BMI more than 30, severe obesity more than 35, morbid obesity more than 40, super obesity more than 50, super obesity more than 60. Android obesity, fat is located in the upper body with truncal distribution. This is associated with increased VO2 and cardiovascular disease. Visceral obesity is associated with cardiovascular disease and left ventricular dysfunction. Gynecoid or peripheral obesity, with fat around the hips, buttocks, and thighs, is associated with less CVS disease. Respiratory changes. Causes of respiratory system changes includes mass effect, increased metabolic rate, and adipokines from visceral fat. Mass effect is due to increased soft tissue mass, compression of the neck and chest, displacement of diaphragm, worse if male, worse if central and visceral fat distribution, better if female, i.e. gynecoid obesity. Increased metabolic rate is due to increased muscle mass and increased fat mass. There is increased body oxygen demand and CO2 production due to increased tissue mass. Adipokines are secreted from fat. Mostly are pro-inflammatory such as leptin, TNF-alpha, IL-6, resistin, angiotensinogen, and PAI-1. Some are anti-inflammatory such as adiponectin. Airway. In the upper airway, mass effect results in reduced radius and increased airway resistance. Mass effect causes reduced range of motion of the head and neck. There is increased risk of OSA, OHS, and obstruction when sedated. There is increased risk of difficult back mask ventilation and intubation. Incidence of difficult intubation in the obese is 13%. For the lower airway, mass effect reduces lung volume, thus reduces airway radius and increases airway resistance. Adipokines causes airway inflammation, airway narrowing, and increased airway resistance. There is increased airway pressure and increased risk of gas trapping. Lung volumes. For static lung volumes, mass effect causes reduced chest wall compliance, reduced TLC, reduced RV, reduced FRC. FRC reduces by 25% if erect at BMI 30, reduced inspiratory capacity, and reduced ERV. FRC declines exponentially with increasing BMI due to diaphragmatic splinting and mass loading. Reduction in volumes are worse if supine and under GA. Increased closing volume causes small airway closure, increased shunt, and hypoxemia, resulting in rapid desaturation after induction. Dynamic lung volumes. Mass effect reduces chest wall compliance and reduces FVC. Mass effect increases airway resistance and reduces FEV1. Increased metabolic rate causes increased tidal volume by 20%. Breathing mechanics. Restrictive defect. Mass effect reduces chest wall compliance, increasing work of breathing, and this is severely impaired in the Trendelenburg position. Airway obstruction. Mass effect reduces airway radius and increases airway resistance. This increases work of breathing. Adipokines causes airway inflammation, and this causes airway narrowing. Alveolar time constants. Time constant equals resistance times compliance. Increased resistance is due to mass effect and adipokines. Compliance reduces due to mass effect, which reduces lung volume and reduces alveolar radius. This increases tension, which is T equals PR divided by 2. Compliance falls exponentially with increasing BMI. Work of breathing increases as a result of decreased thoracic compliance. All this results in increased alveolar time constants, increased variability, increased slope of phase 3 capnogram, and increased peak to plateau pressure difference. Ventilation. Increased metabolic rate increases respiratory rate and tidal volume. There is increased minute ventilation to maintain normal capnia, which further increases oxygen demand. There is accessory muscle use at rest, which increases work of breathing and VO2. There is reduced physiological reserve if unwell, such as in pneumonia or during exercise. Perfusion. Increased metabolic rate increases cardiac output. Concurrent OSA or OHS causes chronic hypoxia with risk of pulmonary hypertension. There is risk of right ventricular failure perioperatively due to pulmonary hypertension. Gas exchange. Impaired VQ matching. FRC below closing capacity leads to shunt, hypercapnia and hypoxia. Gas exchange is impaired with increases in alveolar arterial oxygen difference and shunt fraction. Equilibration with inhaled volatile anesthetic agents may be slow. ABG changes may include reduced PaO2 if shunt, increased PaCO2 if OHS, increased bicarbonate, which can be very high if OHS. pH is usually normal if chronic process. Diseases. Obstructive sleep apnea. During sleep, mass effect causes airway collapse. This leads to hypoxia, increased sympathetic activity, arousal, and deep inspiration due to chemoreceptor reflex stimulation. Then the patient falls asleep again with airway collapse, and the whole cycle repeats again. There is reduced sensitivity to reduced PaO2, increased risk of obstruction and apnea perioperatively. The risk is exacerbated by opioids, benzodiazepines, and other anesthetics. 15% have pulmonary hypertension. In OHS, aka Pickwickian syndrome, which consists of obesity, somnolence, polycythemia, pulmonary hypertension, and right heart failure, mass effect increases work of breathing with associated reduced alveolar ventilation leading to chronic hypercapnia. There is reduced sensitivity to increased PaCO2 and reliance on hypoxic stimulus, which is ablated by volatile anesthetics. 50% have pulmonary hypertension. Cardiovascular system changes. Causes of CVS changes is due to increased fat mass, increased lean mass leading to increased metabolic rate, increased blood volume, neurohormonal changes such as adipokines and sympathetic nervous system, and comorbidities. Summary of cardiovascular effects. Excess adipose tissue exerts increased metabolic demands on the cardiovascular system, leading to increased cardiac output, myocardial demand, cardiac work, arterial pressure, and increased blood volume. There is reduced physiological reserve, increased left ventricular end diastolic pressure, and near maximal stroke volume at rest, increased cardiac output mainly by increase in heart rate, poor tolerance of exercise, post-op SIRS and excess IV fluids, risk of left ventricular failure independent of cardiomyopathy. There is increased risk of multiple diseases such as atherosclerosis and sleep disordered breathing. Changes of the heart includes left ventricular hypertrophy and dysfunction, right ventricular hypertrophy and dysfunction, arrhythmias, and increased risk of myocardial infarction. LV hypertrophy is present in 80%. It may be eccentric if there is increased blood volume, increasing preload, and concentric only if there is increased SVR. Hypertrophy is due to leptin, angiotensin II, resistin, chronic sympathetic stimulation. Reduced LV compliance increases filling pressure. Impaired LV diastolic filling in patients at all stages of obesity is present compared to lean patients. Increased LV filling pressure occurs even with moderate exercise. There is increased risk of type 2 myocardial infarction. Left ventricular dysfunction is due to multiple types of possible cardiomyopathy, such as volume overloaded, obesity-induced, ischemic, and hypertensive types. Right ventricular hypertrophy is present in 30%. Causes includes pulmonary hypertension due to sleep disordered breathing, leptin, angiotensin II, and resistin. Right ventricular dysfunction, LV failure and pulmonary vasoconstriction due to chronic hypercapnia, and hypoxic pulmonary vasoconstriction results in pulmonary hypertension, increased work of right heart, dilatation of right heart, resultant cor pulmonale, and right-sided heart failure. Right heart pressures depends on the contribution of left heart failure, sleep apnea, obesity, hypoventilation, and other pulmonary disorders. Pulmonary capillary wedge pressure and LV end diastolic pressure values range from high normal to markedly elevated. Obese patients poorly tolerate reduced PaO2, increased PaCO2, and acidosis. Increased circulating levels of catecholamines due to OSA, ventricular hypertrophy, fat infiltration of the pacing and conducting systems, coupled with potential hypokalemia from diuretics, increases the risk of arrhythmias. Increased incidence of diabetes mellitus, reduced physical activity, and all the other above-mentioned factors increases the risk of ischemic heart disease. Hyperinsulinemia, hyperglycemia, and adipokines causes vascular endothelial dysfunction, abnormal lipid profile, hypertension, and vascular inflammation, accelerating atherosclerotic cardiovascular disease. Vasculature changes includes hypervolemia, atherosclerosis, hypercoagulability, and increased blood vessels. Increased lean mass increases VO2 and secondary polycythemia. Increased angiotensin II, aldosterone, and reduced natriuretic peptides increases sodium and water reabsorption, which increases ECF and plasma volume. There is increased absolute blood volume and decreased relative blood volume. Obese patients have less water per unit body weight. They tolerate hypovolemia badly, and they may also compensate poorly for changes of position during anesthesia. Coupled with elevation of left ventricular end diastolic pressure, there is increased risk of developing heart failure. TNF-alpha and IL-6 increases the risk of metabolic syndrome and type 2 diabetes, which increases the rate of atherosclerosis. This leads to increased risk of ischemic heart disease and stroke. Hypercoagulability is due to inflammatory procoagulant state due to increased TNF-alpha, IL-6, and PAI-1. There is increased risk of venous thromboembolism perioperatively, ischemic stroke, and myocardial infarction. Each additional 1 kg of fat contains 0.6 kilometers of blood vessels. Adipose tissue is surrounded by an extensive capillary network which has high permeability and low hydrostatic pressure. The resting blood flow in adipose tissue can increase up to tenfold. The interstitial portion of adipose tissue contains a large quantity of fluid. Although cardiac output increases with total fat mass, the perfusion per unit of adipose tissue actually decreases with increasing percentage of body fat. The enlarged bed of adipose tissue in the obese is less vascularized than other tissues. Hemodynamic changes. Heart rate barely changes at rest. Cardiac output increases due to increased stroke volume. There is increased stroke volume and cardiac output. Increased lean mass increases VO2. Increased blood volume leads to increased preload. Increased sympathetic nervous system output increases cardiac contractility. And increased parallel capillaries reduces SVR. All these contribute to increased cardiac output. There is minimal change in cardiac index. There is increased myocardial oxygen consumption and increased risk of ischemia. Changes in systemic vascular resistance is variable. SVR may reduce due to increased lean and fat mass, resulting in increased capillary beds in fat tissues which are parallel in arrangement. SVR may increase due to angiotensin II. Plasma renin activity is higher in obese patients, suggesting activation of the renin-angiotensin-aldosterone system in obesity. Changes in MAP is variable. It may be normal in simple obesity. The patient may be hypertensive if SVR is increased. Hypertension is more prevalent in the obese population, which results in LV dilatation, hypertrophy, cardiomyopathy, which reduces ventricular compliance and leads to diastolic dysfunction, impaired ventricular filling, and increased LV-EDP. Pulmonary vascular resistance. Sleep-disordered breathing, if present, leads to chronic hypoxia and hypercapnia, which increases pulmonary vascular resistance. ECG changes. In simple obesity, due to horizontal displacement of the heart by visceral fat and thickened chest wall, ECG may be low voltage with left axis deviation and flat T waves inferolaterally. In obesity cardiomyopathy, due to fat infiltration, fibrosis and lipotoxicity, there may be prolonged QT interval, AV block, and bundle branch block. Common arrhythmias includes AF, ischemic changes, and changes associated with cor pulmonale such as left axis deviation, RBBP, and small voltages. Endocrine system changes. Insulin resistance with hyperinsulinemia is characteristic of obesity and is present before the onset of hyperglycemia. Hyperinsulinemia leads to increased hepatic VLDL synthesis, plasminogen activator inhibitor 1 synthesis, sympathetic nervous system activity increase, and sodium reabsorption. These changes contribute to hyperlipidemia and hypertension. Peripheral resistance to insulin on glucose and fatty acid utilization leads to type 2 diabetes. Obesity predisposes to metabolic syndrome, which is occurrence of several metabolic risk factors for both type 2 diabetes and cardiovascular disease, such as abdominal obesity, hyperglycemia, dyslipidemia, and hypertension. Visceral fat appears to provoke chronic low-grade inflammation that may trigger both insulin resistance and hypertension, atherosclerosis, and diabetes mellitus. There are anorectic and orexigenic neurohormonal factors which regulate energy balance, and in obese patients the balance between the two systems is disrupted. Subclinical hypothyroidism occurs in 25% of obese patients. Gastrointestinal or genitourinary system changes. Fasting gastric volume and acidity increases. Gastric emptying time is delayed because the increased abdominal mass causes antral distension, gastrin release, and high gastric acidity. Obese patients are more likely to have increased intra-abdominal pressure, which leads to increased risk of gastroesophageal reflux. There is increased risk of developing a hiatal hernia, with increased risk of reflux and aspiration. Hepatic impairment due to non-alcoholic steatohepatitis, NASH, and cirrhosis may occur. There is increased risk of cholelithiasis, breast and endometrial malignancies, and renal damage from cardiovascular risk factors. Hematological system. The risk for deep vein thrombosis and pulmonary embolus doubles due to procoagulant state, due to polycythemia from chronic hypoxia, venous stasis due to physical inactivity, and chronic inflammation that activates prothrombotic pathways. The pro-inflammatory and hypofibrinolytic effects of obesity may be exacerbated by dysregulated expression and secretion of adipokines and microRNAs, leading to endothelial dysfunction, plaque rupture, platelet activation, and delayed clot lysis. Obesity leads to disruption of the balance between prothrombotic adipokines such as leptin, PAI1, resistin, and visfatin, and antithrombotic adipokines such as adiponectin and apelin. Nervous system changes. There is increased risk of cerebrovascular accidents and neuropathy. Sleep-disordered breathing leads to hypoxia and hypercapnia, which causes increased cerebral blood flow and may increase ICP in susceptible patients. Transport of leptin across the blood-brain barrier may be inhibited by excess triglycerides, reducing leptin activity in obese patients. Leptin is produced by fat cells and acts on NPY and AGRP neurons to decrease food intake. B. State the implications of these changes to the anaesthetist. For the respiratory system, difficult auscultation, difficult intubation, difficult tracheostomy, difficult ventilation with high airway pressures, difficulty in maintaining perioperative oxygenation, risk of aspiration pneumonia, risk of postoperative respiratory failure, risk of failed extubation, possible need for non-invasive ventilation postoperatively, and increased sensitivity to opioid-induced respiratory depression. Cardiovascular system, difficulty in auscultation and palpation, labile blood pressure, increased risk of DVT, pulmonary embolism, ischemic heart disease, and heart failure. GI and GU system, difficult palpation, and increased risk of regurgitation and pulmonary aspiration. Endocrine or metabolic, labile blood sugar levels. Other implications includes difficulty in monitoring, such as NIBP, ECG, and SpO2. Chest X-ray and ultrasound or other imaging are of poor quality. The patient may not be able to fit in a CT or MRI machine. Poor wound healing, increased difficulty of all practical procedures, such as vascular access, regional anesthesia, urinary catheterization, etc. Problems with manual handling. Consider logistics of mobilization, postural positioning, and pressure area care. Wide range of potential comorbidities, and mortality from all forms of surgery, average twice that of the non-obese population. Pharmacokinetic implications. Absorption. Gastric emptying is unpredictable. Gastric emptying may increase, leading to high oral peak dose. Gastric emptying may decrease, for example, post-surgery, leading to lower peak oral dose. Poor subcutaneous fat circulation leads to reduced absorption of subcutaneous and transdermal drugs. Thick adipose tissue layer leads to difficult intramuscular, neuraxial, IV or LA injection. Distribution. There is increased absolute and proportional amount of body fat, increasing volume of distribution for lipophilic drugs, such as benzodiazepines, lidocaine, thiopental, and verapamil. There is increased total body water, increasing VD for hydrophilic drugs. There is increased accumulation of drugs in the fat compartment, leading to prolonged drug effects. If heart failure is present, reduced blood flow delays drug onset and distribution. Fatty acids may compete with drugs for protein binding sites, leading to increased free drug fraction and drug effects. Increased alpha-1 acid glycoprotein levels leads to reduced free fraction of certain drugs, such as propranolol, and reduced effects. Metabolism. Hepatic blood flow may increase due to increased cardiac output, leading to increased clearance of high extraction ratio drugs, such as propofol. Hepatic blood flow may reduce due to heart failure or cirrhosis, which delays hepatic drug clearance. There is increased CYP2E1 activity. Metabolism of some pathways are increased in the morbidly obese, such as phase 1 hepatic reactions, oxidation, reduction, and hydrolysis. Increased phase 2 enzyme activity leads to increased hepatic clearance. Increased soluble enzyme activity leads to increased substrate drug dose requirements, such as succinylcholine. Elimination. Half-life of lipophilic drugs may increase due to increased volume of distribution. Increased cardiac output leads to increased renal blood flow, increased GFR and renal clearance of hydrophilic drugs. Increased tubular secretion leads to increased clearance out of proportion to increased GFR of certain drugs, such as ciprofloxacin, cimetidine, and procainamide. GFR may reduce due to diabetic nephropathy, and this reduces clearance of renally excreted drugs. Biliary clearance may be slowed by bowel stasis or existing biliary duct disease. Pharmacokinetic data in obesity does not exist for most drugs. Underdosing and overdosing is more likely than with individuals of normal weight. Monitoring of therapeutic levels is important. There is problematic determination of drug dosages in the obese population. Pharmacodynamic implications. Reduced dose response is seen for certain drugs such as verapamil, oral contraceptives, atracurium, and insulin. Increased dose response is seen for certain drugs such as triazolam and respiratory depressants such as opioids and anesthetics. Additional information. Problematic determination of drug dosage. As a summary, in people of normal weight, total body weight equals ideal body weight equals lean body weight. No equations are required. Most drug dose instructions refer to total body weight. In morbidly obese patients, total body weight overestimates the dose, ideal body weight underestimates the dose, lean body weight is probably the best estimate of dose. For most non-lipophilic drugs, ideal body weight is sufficient because volume of distribution does not change. For strongly hydrophilic drugs, instead of calculating lean body weight, 20% can be added to the ideal body weight to account for the increase in lean body tissue content. For strongly lipophilic drugs, in the case of many anesthetic agents, lean body weight is the ideal metric. The gold standard measure of body composition is cadaveric measurement, which is not practical, total body weight, and pharmacokinetics. Dosing recommendations are generally based on total body weight. This is fine for normal people, where TBW equals ideal body weight. With increasing obesity, fat mass accounts for an increasing amount of total body weight. However, the majority of cardiac output still directs to lean tissue groups. Dosing a drug to total body weight in morbidly obese individuals may result in overdose. This is a graph of body weight against BMI. With increasing BMI, there is increasing total body weight, increasing lean body weight, which plateaus, and increasing fat weight, which increases almost linearly. Ideal body weight and pharmacokinetics. Ideal body weight is the ideal weight associated with maximum life expectancy for a given height. It may be calculated with the formula height in centimeters minus 100 for males and minus 105 for females. The assumption made in this calculation is that inside every morbidly obese patient, there is a mass of lean tissue which is ideal for their maximal life expectancy and which is directly proportional to their height. All patients of the same height would end up receiving the same dose if we use this metric, no matter how much they weigh. This assumption is clearly incorrect, as obese individuals tend to have more lean body mass than normal people. However, in most cases, in morbid obesity, the volume of distribution of non-lipophilic drugs is fairly stable and is related to ideal body weight. Body surface area is used commonly for dosing of chemotherapy agents and is virtually identical to ideal body weight in terms of disadvantages. Equations used to calculate BSA contains total body weight and height. The Mosteller equation is the most commonly used. Body surface area in meters square equals square root of height times weight divided by 3,600, where height and weight are in centimeters and kilograms respectively. Like ideal body weight, this method ends up offering a similar dose to patients of the same height and does not account for the marked inter-patient variation in drug handling. Lean body weight and pharmacokinetics. Lean body weight equals total body weight minus fat mass. Lean body weight is significantly correlated to cardiac output. Lean body weight is probably the best method for dose adjustment for morbidly obese patients. Many equations are available to estimate lean body weight. Unfortunately, at extremes of morbid obesity, this equation underestimates lean body weight and can even yield negative values, which has certain implications in total intravenous anesthesia pharmacokinetic models.